Welcome into the Psych with Mike Library. This is Dr. Michael Mahan, and I am here with my good friend and colleague, Mr. Brett Newcomb.
Good morning.
Good morning. We were just talking before we started this morning about the longevity of our friendship and the evolution.
And how surprised both of us were that it lasted.
Yeah, well, I know that I am certainly surprised that it lasted. I remember the first time that it occurred to me to speak to you. For people who don't know this, you were a graduate professor of mine,
Yeah.
and I was taking, it was a summer class, and it was the last class that I was going to be able to take with you. I'd taken all the classes that you had taught at the university, and at the last class, walking out, I thought, oh, I just have to ask him, would it be okay to call him sometime? And I remember I was really scared. I was really tentative, and I said, oh, would you maybe want to go out and have lunch or something sometime? And you said, well, I don't know. Call me and we'll see.
Yeah.
And I was like, oh, okay.
I actually remember that conversation.
Yeah.
And then over the years, we've gotten to be very close friends, and both of us have had people say to us independently, you actually like that guy?
Yeah. Well, I think that probably on the surface, most people experience us as very, very different people, even though I think that you and I probably agree that
I have more charm and grace, and
I think there's a lot of people. I think there's a lot of people who would say yes, that's true. But I think that you and I probably experience ourselves as much more alike than most people do.
Yeah.
Yeah.
Especially when it comes to clinical concerns and clinical issues,
Right.
Which is what we're going to be talking about today in terms of the diagnosis of narcissistic personality disorder, or the topic of narcissism, which is a great topic for both of us to talk about, being narcissistic.
Because we've been accused of it multiple times.
Only by lesser minds.
I would agree with that. They're all jealous.
Absolutely.
Yeah. But this was something that I wanted to talk about, and I wanted to start off by saying that there are certain terms in psychology that I think are colloquialized, and I think to the detriment of the meaning of the terms, but also to the detriment of the understanding of most people. Terms like narcissistic, terms like sociopathic, terms like borderline actually have real clinical meaning.
They do, but when you start to talk about this stuff, you have to think in terms of the distinctions that get made between the pure sciences and the social sciences. Mm-hmm. And the idea behind science or scientific is that you can conduct an experiment or do a test, and you can get specific quantifiable data, and that someone on the other side of the world can use your methodology and replicate your results. But when you're talking about things like diagnostic labels in psychology, that can't be done.
Right.
I mean, we have to have a box, a conceptual framework for clinicians to be trained in terms of theories about the development of the self, theories about defense mechanisms, resistance, all the things that we talk about in order to be trained to do therapy. But then we have to remember the warnings that come from professors like Irwin Yalom, that the diagnosis is not the client. Mm-hmm. And so we need to make a diagnosis at some point, or at least we're taught that we do. But we go into the room to try to help somebody, and we have to remember the goal is to help them improve the quality of their lives, the experiential quality of their lives, not our objective judgment about the quality of their life. And that doesn't have anything to do with the diagnosis. It has to do, the diagnosis can give you framework guidance. Let's explore this. But it doesn't define the person in front of you, and it doesn't necessarily help them to be able to give them a label. And some people will say, oh, that's it. That's all I just wanted to know. What do you call this that I've got?
Right. And you're making actually a really great point that I hadn't articulated even in my own mind as...
That happens so often.
Completely. But this idea that people aren't those diagnoses, and I think that is very salient, and I think that for me is what I don't like about people who use these terms colloquially. I remember when I was first starting out and working in an institution, and the nurses would always, whenever there was a female client that they didn't like, they'd say, well, she's borderline.
Right. Yeah.
And it was just kind of a something that they tossed in, like I'm a professional. I have this knowledge and I have the right to make this diagnosis.
Right.
But really, it was an accusation of the person, not an actual assignment of a clinical diagnosis.
Well, and transference or countertransference. It was protective of their self-image. If I can't reach this person or help this person in a way that makes them appreciate me, then there's something wrong with them. Because I know I'm a good person and I'm here to help, and I know what I'm doing.
So, narcissism occupies a place in psychology, which are called personality disorders. And,
but even sooner than that, the theoretical foundation of personality development starts with the concept that babies are grandiose narcissists, and that we all have narcissistic traits. So then, as you study psychology and you get into the framework of mental illness and emotional disturbance and so on, and trying to understand it, you have to have a way to think about it.
Right.
So then you encounter these terms like narcissistic personality disorder or personality disorders in general, the axis 2 disorders, which cluster, and it's really hard to make precise distinctions among them, like sociopath versus narcissist. So those are sort of intellectual entertainments for therapists in training and therapists in practice. But what you're saying is ordinary people who've heard these words throw them about as if they have valid meanings that they understand, and that bothers you.
Well, and that, as you had said, that they use those things as an assignment of some kind of judgment of the person. Like, well, my boyfriend's a sociopath. I knew it.
Yeah.
Or, that woman is borderline. I knew it. And like, okay, now that explains everything. And now this person, we've assigned this label to this person, and this person is that label.
Yeah.
And what you're saying, and rightly so, is people are so much more than any label can define. And I know you and I, because we have never operated within the realm of insurance reimbursement, we're very reluctant to ever assign a
diagnosis, because people go look it up. They go, they got the web. And so you say, well, I think you've got an adjustment disorder, which, and when I was teaching in school for other therapists to become therapists, I said, you always choose the least damaging but most legitimate diagnostic label that you can find. So you don't throw something out there like, oh, he's suicidal or he's got suicidal ideations, because that can damage them down the road if they need a security clearance or they're trying to buy life insurance. Or, and so you don't want to cause harm ever to your client. You want to help your client. But if they're suicidal, you've got to say so. But there may be some other categorical label that you can use that's less damaging.
Right.
And what we found what I found when I first started, and still was dealing more with insurance companies, is that I would find that idealized label and start using it, and all the other therapists were using it. So 2 years down the road, the insurance companies would say, well, we don't pay for that label anymore. So then you got to go back to the drawing board and find another one. So when I got off of that merry-go-round at the end, the most acceptable generic label was adjustment disorder with mood fluctuations. And my clients would say, well, what does that mean? I read about it, and I don't know what it means. I said, it means crap's happening in your life.
Right.
Oh, yeah, well, that's true. And so then they were more okay with that.
Right.
But I stayed away from those other heavy-duty labels, especially Axis 2 labels. And there's some discussion in our field that people with our qualifications, which we're both licensed professional counselors. Now, you have a PhD, and you're also a licensed psychologist. You, more so than I, would have acceptability for using an Axis 2 diagnosis. But as we go up the medical food chain, there were people that said, I wasn't qualified to make an Axis 2 diagnosis. Legally I could, but they said clinically you're not qualified unless you can demonstrate to their satisfaction that you know what you're talking about. So that's your reputation and your history and your connections in the community. But I was always mindful that I preferred to have that diagnosis come from somebody further up the food chain to put in my records, but that I still worked with the client from the same approach, doing the same things, no matter what the label was.
Right.
Because my objective is to help you get your life in a place where you're not in pain and you're pretty satisfied with who you are.
And just a point of clarification, I'm not a licensed psychologist. I have a doctorate in clinical psychology.
You're a psychologist with a license, but you're not a licensed.
Exactly.
Yeah.
Right. But if I say that, then
I know.
I'll get in all
professional
kinds of trouble.
jealousy. Yeah.
So going back though specifically to narcissism, which is an access to personality disorder, and it is something that we've discussed multiple times. We used to work in a practice together, West County Psychological Associates in St. Louis, Missouri, and one of the things that I loved about working there was that we would have a Wednesday morning clinical meeting.
Right.
And one of the things that
Who was the clinical director for that?
I believe you were.
Oh, okay.
Yeah. And one of the things that I always loved about that clinical meeting was that we really enjoyed having those deep in the weeds kind of clinical discussions.
Yeah.
And oftentimes we would talk about very Freudian concepts and specifically access to personality disorders. And I think that it is important for people to, especially clinicians, to have an operational understanding of those things,
right,
because these are actually things that do apply to human psychology.
Right.
And whether you're ever going to use that as a diagnostic label ever in your career, understanding how these things operate in the field of human psychology, I think is important.
Well, there are two elements there. One is that understanding, which enables you to approach getting the roadmap of the client. What are the patterns in their life? What does this fit against? But the other is professional credibility. Mm-hmm. When you speak to other professionals, if they go to the hospital,
right,
if you're dealing with a psychiatrist, if they move to Georgia and they come into therapy in Georgia, and somebody contacts you and says, "Well, what's going on?" You need to have that credibility, and if you don't have that common language and that common structural conception, you can't communicate with them and get any validity.
And so diagnostic labels are really just shorthand nomenclature, yes, for professionals to be able to talk to each other. Exactly.
Right. And they shouldn't, and they're not meant to be used by the insurance companies to limit the number of sessions. Oh, they got that. They should be done with that in about 8 sessions.
Right. They're not meant
in 3
to
months.
They're not meant to be,
No,
but they are.
They have evolved.
Yes.
Yeah.
So when you were talking about babies are grandiose narcissists, yeah, which is that's a Freudian definition, right, of how they are when they're young. My Piagetian definition of that is egocentric, and that just means, yeah, that they don't have the ability to perceive the reality, the perceptual reality of somebody, not them. So a baby cries in the middle of the night. The object is
an extension of their, yeah, will or their need.
But they'll cry in the middle of the night. The baby cries in the middle of the night and doesn't take into consideration how many people in the house that they wake up.
Right.
They don't have the capacity to do that.
Why would they care? Yeah.
Right. And then as we get older, we're supposed to learn, you shouldn't scream out in the middle of the night unless there's a legitimate emergency, because that is not appropriate.
That's part of what you learn growing into a person. Mm-hmm. I mean, it's the old tabula rasa thing. Well, part of the problem with psychology is we have all these complex concepts, but we only have a half a dozen words. Mm-hmm. So when you always have to give extended paragraph descriptions of which angle of the facet of the diamond you're looking at. So if we're talking about the development of the ego and the development of the self and the grandiose narcissism of the infant, because he doesn't know that his baby brother is a completely different person with needs and issues of his own. But as, right, he grows up, he needs to learn that,
right, and
to interact with those other people. But when you're just a baby, you don't know that. You don't care about that. You just have the Freudian theory is that the id is in complete control at that, mm-hmm, time, because the ego hasn't developed yet.
Right.
So the id says, I'm hungry, I'm wet, I'm cold. Somebody do something, or something, life do something to take away this discomfort.
Right.
And they get mad.
Right. And so I'll put up a slide that talks about id, ego, and superego, okay, just for people who, we are talking about this because we have a lot of knowledge about these things. It's secondhand to us, but people who don't have that training, so that there'll be some clarification for that. But then as we grow up, if we're talking about somebody who is an actual narcissist that you could actually clinically, right, diagnose, then what we're saying is that individual didn't develop the regulational capacity to be able to bind that part of their psyche. So they have a similar kind of thought about themselves as a person in space as they did when they were an infant.
So the short term interpretation of what you just said is that they don't have any empathy. They don't have empathic connectivity.
Well, I would associate that more with sociopathy. I think narcissists can have empathy.
I disagree.
Do you?
I don't think they do. I
Okay.
think that they can be incredibly seductive and manipulative, but it's always in service of their right to get what they want. Whatever that may be. What I want is to see you be subservient, tug your forelock, bow your head.
Yeah.
What I want is to have the biggest pile of whatever it is that I desire. So that doesn't involve any empathy at all.
Well, I think that it may be true that narcissists don't employ empathy as a rule in the way that they operate, but that they have the biological capacity, and that if they change, they can learn how to use empathy. I don't believe that sociopaths have the biological capacity for empathy.
Well,
And that's a subtle difference.
again, I would disagree.
Okay.
I think if you posit that the biological capacity is there, it's there. The question is, how do we tap it? How do we develop it? How do we encourage it? Otto Kernberg says, who's the major voice about access to disorders in our field, one of two, Masterson being the other. Kernberg says, you can't change a fundamental personality disorder until you're in your 40s or 50s, and even then you can't change it unless you really want to. And that's the trick of dealing with a narcissist. When you're working with somebody that's diagnosed as narcissistic personality disorder from a clinical perspective, you have to understand as the clinician there are very limited areas in which you can make progress, in which you can help them stabilize their lives or their relationships. You're not going to cure them or fix them. They have to get to a place where they really are hungry for a change in how they experience themselves and in the connectivity in their life. And so you have to just put them in a safe holding environment and keep them from being destructive until they can get to that age and that place where they have a place to stand in and say, going forward in my life, I want to be different. And it's hard work. And it's frustrating work for the clinician.
And so I always do like a ton of research on these things,
Yeah.
and then I put all the show notes up so people can see those.
And I'm
whether
grateful for that.
on the podcast or you're on the YouTube. A lot of this really deep clinical information is in the show notes. Some people don't want to dive that deep, and that's fine.
Yeah.
But what I would then say, and I would be interested if you would agree with this, is you have a very Kernbergian, I don't know if that's a word, perspective
Approach,
on narcissism. I have a very Kohutian perspective. So Kernberg did believe that this was very entrenched, and probably did believe that empathy was not an achievable state for somebody who was a narcissist. Kohut believed that this was just about the object integration and
twinship mirroring.
And idealization.
Yeah.
And that when you don't have a good model when you're growing up, then you don't develop those internal regulation capacities, and then you carry that perspective into adulthood.
Yeah.
And when you get into a relationship, as with a therapist, and that is really deep and trusting, that over time you can unlock that kind of. So what happens is, that the person in therapy then looks at the therapist as a surrogate parent, so an external object, and idealizes them and adopts their maladapted perspective of what the internal object is to more coincide with the therapist, and then internalizes that, and then they learn how to be better regulated.
Would Kohut say that the objective of therapy is to reparent
I think that's
dysfunctionally parented person?
Yeah.
I would agree with that.
Yeah. But because he believed that the individual had the capacity, the biological capacity for empathy, that you could then turn those states on and the person could learn how to then be empathetic. I think Kernberg was less convinced that that was true. I think Kernberg was more stark in his perception of it, much the way that you were defining it earlier.
I think I agree, because I've studied both of them, and I think, and I don't have any evidence for this, and I'm just remembering vaguely from somewhere, I think Kernberg worked in a mental hospital where he saw a much more severely disturbed population.
Right.
And so his frame of reference, his understanding was defined by the population that he saw.
And Kohut worked at the University of Chicago alongside another guy that we know well in therapy, Carl Rogers, and they despised each other, by the way,
yeah.
hated each other. Yeah, it was, but that's for another day.
Yeah.
So if we're kind of on the same page with this idea of how we go about that in therapy, what would you say for you are the best ways of bringing this into the therapeutic milieu and really trying to, because for me, what I would say is that it's really genuinely, and we just mentioned Carl Rogers, I did, and for me, it's really all about establishing that trust, what you would call that safe emotional holding environment.
Right.
That is essential, especially in therapy like this.
Yeah, and make sure that you don't get distracted by the label and lose sight of the person in front of you. Create a safe holding environment for that person to have a place where they can safely look at themselves and what works and doesn't work in their life, where they can learn to be more. And I always tell them, you can lie to me. I don't need to impress me. You need to be truthful to yourself. And so what is it you really want? What really hurts? What are you really angry about? And how do you handle those hurts, that anger? Is it successful in your life? So I don't come with an agenda of what will fix you. I come with an agenda of being able to listen to you and help you listen to yourself honestly, so that you can then make different choices if you choose to, and if you decide they're affordable.
And I really like what you're saying about you can lie to me, but you can't really lie to yourself, and it's important for you to be honest about that. And that really dovetails into, we're going to next time talk about resistance in therapy, which is something that really is exactly down that alley. So for people who are listening to this and thinking, oh, I want to really understand more about how that process in therapy works, check out next week's episode when we talk about resistance, because that's really about how do you get into that thing about, how, to me, that's really where therapy breaks down. You say to the individual, you can lie to me, but you can't lie to yourself, and it's important for you to be able to be honest with you. Right. People who want to get better are willing to hear that, and they're willing to try and make that attempt. They might not be successful.
No, I say the exact same thing, but I say it a different way. I say if you're ready to change, therapy will be quick. If you're not ready to change, we're going to have to dance for a while.
Well, even if that's not quick, I mean, they're willing to make that effort. For people who aren't willing to make that effort, I mean, that's when they just don't come back, because they're not willing to hear that. But I still think it's important for us as therapists to say that.
Well, some people come with an agenda.
You can't be afraid to lose a client.
Oh, no, absolutely not.
Yeah.
And some people come with an agenda to fail, especially in marriage counseling, because they want to be able to say, they don't want it to make a difference. They don't want to help change so their marriage can be saved. One of them wants out, but they want to be able to say, even marriage counseling didn't help us.
Exactly. Yeah. So this actually ended up being a fantastic discussion, so thank you very much for that. As always, the music that appears in Psych with Mike is written and performed by Mr. Benjamin DeClue. If you want to get a hold of us, we now have a little icon in the bottom right-hand corner. Click on that if you're watching us on YouTube, and subscribe, like our videos. That really, really helps us out. And for both Brett and I, if it's Friday, it's Psych with Mike.